So coming to the next panelist, we'll quickly go through the slides, but I would really love them to introduce themselves. These slides are just their what we know about them, but Tejal, Chitra, Dr. Manash, and we have a new panelist, Asha. So Tejal is an endocrinologist practicing in Navi Mumbai. What about next slide? Chitra, she is from Bangalore. She is an associate professor in Ramaya Medical College. Is that right, Chitra? Next slide. And Dr. Manash Baruah has joined us from Assam. Next slide. And Asha, I think Chitra, if you can introduce her, and then I would like to listen to all of you introducing yourself. So Miss R. Asha Vishwanathan, she's been working with Bangalore Akashwani, All India Radio for 25 plus years. Welcome, Asha. This is the first time I am interacting with you, and she's a radio jockey with FM Rainbow, voice trainer, a modulator, creative consultant. So all these introductions are there on our website also. Now I think we'll move to the session. We are a little late now. Let's start the discussion. The round one, when you're answering your own questions, I would also want you to first tell about yourself in brief. So Dr. Manash, starting from you, what is your philosophy in the clinic?
Thank you for that question. Yeah, my philosophy is very simple. When I approach a patient, I would first like to treat a person, and then I would like to treat the disease, and finally I would like to treat the reports. Unfortunately, in many instances, we see the reverse nowadays. People are pretty fast nowadays, and people want to treat the reports and leave out the rest two parts: the person and the disease. Sometimes disease is forgotten, and sometimes I would like to broaden the horizon by including the family in the game. Like I would like to treat the family. For example, my patient is sitting here. It's a true case actually. The couple was there. The husband is a diabetic. He's an engineer, and then that day he brought his two daughters and tiny little dolls, and then the wife was crying. She was saying that, sir, he is too much into alcohol. He can't control. And that guy he's an engineer, graduate, working in a government department. It's a good salary. Everything is fine. Two daughters. Then that moved me too much. I said, I need to involve now the family in the whole thing. I cannot just treat his blood sugar, HbA1c, creatinine, and just cannot give him some advice regarding diabetes lifestyle, but I need to treat so I first started addressing the family issues. So I tried to counsel him, and actually I kind of blackmailed him into giving up alcohol. I said, you just look into the eyes of your daughter, younger daughter, and from now onwards, whenever you drink, you try to remember her eyes. After 6 months, that gentleman came back to me. He said, I gave up, sir. Those two words compelled me to give up when the wife was smiling. So that's my philosophy. I mean, if you can include the family first, then the person, then the disease, and lastly you try to address the technical issues like reports, blood sugar, creatinine, uric acid, lipids, whatever. These are necessary, but they're not all. So that is my philosophy of treatment in short.
I think next we move to Chitra. You'll take over from here.
Yes, sure. Thank you, Dr. Beena, and thanks for the interesting introduction talk which happened, and thanks, Dr. Manish, for that candid presentation. So I'm extremely happy to be joined by Ms. Asha and also Dr. Tejal and Dr. Manash. So Dr. Beena has given us a very important brief, right, to talk about whether there is, in the doctor-patient relationship, is there a hierarchy of power? And should we even look at that relationship in terms of power? So maybe I'll start with Asha. And Asha is in a unique position because she is a counselor, and she does that as well. And she also is seeking care for chronic conditions. So she would have done both sides, and I would really love to see her thoughts on whether doctors and patients, is there a power hierarchy? Does that, or should that in some way dictate or at least show us the way how we should respond and interact with each other? Over to you.
Yeah, well, to begin with, hi everybody, and thanks Dr. Chitra for inviting me to this distinguished and unique experience I'm getting out of this panel discussion. Well, you are asking me as a caregiver, there is definitely a hierarchy in the business. We call it business. Yeah, I do agree with that. When it comes to taking the power or something, it is not that you are shadowing over, or you're a patient or client or whoever. It is like you have the authority. Okay, this person has come to me. I have to, treat her or whatever, and or I have to give a solution. Then you have to. I think Dr. Manish was mentioning about the addiction case, where he included his family and tricked his the client's father to look into her eyes whenever he feels like drinking, and asking him to get away with it, give away the habit. That would be the power, seeking tactics. I feel like that. And in fact, whoever comes to me seeking counseling or any solutions, I see it as a holistic approach. I'm not authorized to give or suggest medications. I just go through the person first. What might be the root cause of her or the client's emotional baggage? I deal with them with first emotional and their practical lifestyle, and then the family. If the person is ready to accept the family to be included in the counseling sessions, I go. Otherwise, no. There is no force for them to get the family to the counseling sessions. If they are willing and accepting, then they will jump in. And I also do some maybe tricks of the trade, you might call it as. I do meditational healing. I teach them how to meditate. And I also treat through pranic healing and Reiki sessions. All these comes in whoever needs whatever technique I apply. And there is always a power game in here also. For example, if somebody comes to me seeking a counseling session, and I wholeheartedly accept that person, and I start giving solutions or suggesting solutions, and suddenly if something that person is not ready to accept, and they go to some other counselor, then I feel here, like, oh, what went wrong? I should be the, a healer for the person. Then I play the, there are many counselors. You are in the field, you will be knowing many of the counselors doing similar this thing. And I keep talking to them, taking notes on the client who approached me first and now seeking help from somebody else. So I would think there is definitely some authority over your patient, but that should not take over the emotions or the well-being of the patient. That's it. That is how I approach it.
Can I just make one comment? Is it authority, or is it somewhere that as doctors, and I'm asking you frankly, we feel a sense of ownership of the patient? Because this has come again and again in conversations over the past 1 week. So I'm actually going to write a blog. Dear doctor, referring my patient. What do you mean my patient? The patient doesn't belong to anybody. So more than authoritative, I think we feel a sense of ownership about the patient. And that is something I think it's time we let go as a community. Chitra, back to you, because in all our meetings and in all our writings, Chitra is the one who lays out power hierarchy. The first time she spoke about it, I'm confessing this live on camera, I had no clue what she was talking about. And it took time for me to listen to Chitra to understand what she meant by power hierarchy. Chitra, over to you.
I just have, I want to put the another view. Like when you say it's my patient, it's a sense of belonging also. Is it not a sense of caring? It's not only authority. kind of I own the patient, but it's I own it in a good sense of terms. Like I own it because I want to give something good to the patient, as if she is part of my own broad family. So probably most of the doctors are using that term for that purpose. Is it not so?
Yeah, so I think we're so used to defending our own kind that we always come up with an example to protect ourselves. Dr. Bansal, let me give you Dr. Baruah, let me give you an example. A GP referred a patient to me, and I felt that the patient didn't need an endocrinologist, and I referred them to a gastroenterologist. So the GP called me and said, "How dare you refer my patient to a gastroenterologist without taking my permission?"
Oh,
so I'm just using this to illustrate. I'm not saying that you and I are doing this. Maybe we have the best intentions, but somewhere in the fraternity, there is a feeling of ownership. And yeah, sorry, I didn't want to be so mean, but yeah.
No, can I make a point here? See, this is actually very common in some of the places. So this practice, especially I think it's a Mumbai area or something. I was previously in Indore, and where this was very common. And key that if the GP is referring a patient, then he is dictating the specialist of how to treat this patient and whom to refer this patient. This is very wrong. We fortunately here is most of the time, if you are like in Medanta at least, we don't follow this. So if my patient, if I send to somebody, I am nobody to ask what he's doing. Whatever other specialists think that this is right for the patient, and whatever, if somebody sent patient to me, then I also don't feel obliged to tell him that what I am doing. I am doing whatever is best for the patient. I am doing referring whatever I think that he should be referred to. But this practice of doing this has actually polluted, or then we are being GP is no person who can tell you what to do, how to treat, whom to refer, what has to do. And this is actually, I find it totally disgusting that some people can do that.
But Dr. Bansal, if I may ask you, that patient who comes from a small place, who do you think is going to bank on and get support from in the next few years to come?
No, see, I agree with your point. Support is, I am not telling that person not to go back to his doctor. I will always tell that once we have taken
if I may interject, I know you're not telling him not to go back, but is it right to shake up the emotional and, shall we say, the dependence that they have on their local GPs? Because, that actually causes a little bit of a sense of vacuum in the confidence level they have in their own people who are their care providers. And let's face it, the main care providers is actually most of the time the GP. You see, what do I do when I have patients from very far off places? I always tell them in the night, if you have a problem, the doctor who's attending upon you is the best doctor. I mean, the person who is 2,000 kilometers away may be a very, very highly qualified doctor, but is not the best doctor at that point in time.
You are right. You are absolutely right. I don't disagree with that. I am not telling that part is not the. I would also tell go to the nearby doctor, go to the person whom we are seeing, but he cannot tell you what treatment to do.
Okay, I will cut the debate here.
I don't agree on that part.
I'll cut the debate here for the sake of time also. And I think there are points on both the sides. And quickly, a patient has probably written that I think it is not ownership, it is accountability of personal level. My mom was hospitalized due to severe infection, and the doctor took it on himself that he will ensure that she'll be cured. And he asked for other consultations, but he was overseeing it. It was not, he was upset on it, but he was feeling personally responsible. I guess it cuts both ways. I think that settles the point there. There are both stories, both sides of the story. Let's go ahead. Where were we?
Chitra will be speaking.
Yeah. So we've been constantly in the last few days talking about how we should have a better communication. We should listen to our patients more, and we should pay more attention to what each person is trying to say, instead of us using the cookie cutter technology or method of treating our patients. And every single time we keep thinking about, but why should doctors do this difficult work? Why? I'm already doing so many great things. I'm saving lives, I'm treating patients, my day is so busy, right? So how do I make that point shine through? The example I use that is this. Now I have 3 endocrinologists here who are my friends, Dr. Tejal, Dr. Beena, and Dr. Usha. Now Tejal is as good as my sister, and I can say anything to her. I know that she'll get it, and then I can really say anything to her, even if it is highly critical of the way she did something, conducted herself, or anything at all. With Dr. Beena, I might have some reservations to say everything as candidly. With Dr. Usha, because we revere her so much, I might slightly withdraw some of my criticism and hold something back. And in that, I think there is a subtle power shift between all 3 different relationships. Now, I gave the example with 3 endocrinologists. Now, I'm quickly going to ask all the doctors who've logged in to think about your own relationships, right? You and your spouse, maybe. I'm not going to debate about where the power rests, but we all do know that in every single different aspect of life, maybe the decision-making power or it kindly shifts slightly different. Then think about your friends. Your relationship with all your friends are not the same. There are some friends who are able to maybe coax you to do certain things, and there are some other friends whom you can coax and you can coerce to do some other things much more easily. And then if you now think of this relationship, how dynamic that whole thing is, and then think of your patient walking in, and you're sitting there in the comfort of your cabin, and your patient walks in, completely new person, and then you're asking extremely personal, already gotten into my space, check my weight circumference, and I'm coming already with a complaint which is already making me feel less human. And I do think in that particular situation, there is a power hierarchy in place. I think the patient is coming vulnerable, primarily because of that interaction, not because the doctor is a great soul or something, but in that interaction, the power rests with the doctor. And I think that's exactly why every little thing we do, every little thing we say, every little thing, our face changes, the body language, everything has to be carefully thought out, carefully considered, because we are sitting at that power of that position of power. This is my thought. I quickly would like to hear a round of what everybody has to say. We'll start with Dr. Manash. She's looking very weirdly at me.
You sounded very much like police, this team. Every little thing you do, it's like magic. Anyway, actually, because your encounter with your patient is on brief, it's 10, 15 minutes. I mean, if you are spending more than 15 minutes, maybe you'll be considered a fool in today's rat race, but then I do think that is a privilege. So I spend 10, 15 minutes with my patients. Actually, whenever I first encounter my patient, I don't talk about the disease. I talk about where he belongs to, which part. I know entire geography of Northeast region reasonably well. So I can actually identify a common ground. And I, implore on that and expand it to the conversation. Initial, like what profession he is in and how is that particular place in his near his hometown, and how is the weather, how is suppose he's a cultivator, I will say how is the cultivation. If he's an army man, how is it like living away from the family, how are the facilities, how tough the life is. So I kind of find a common ground, and then I go into the disease part. So I won't start with why you are coming here. If I have to ask the patient, sometimes when I see that reports are good in 30 seconds or 40, why you are coming here? You don't need it. I don't treat healthy persons. I treat diseased person. You are healthy. So that even breaks the ice. The person is comfortable. So you have to find a common ground. And next, actually, between sympathy and apathy, you have to find out empathy. That's probably the best word. And I have learned from Dr. Amini, my teacher, and she has got huge influence on my dealing with my patients. I always try to be patient and not look into the situation outside my chamber. People are restless and they're angry, but then when they come into me, and I try to say that, okay, this is my time and his time or our time, so let us together, and I have got good results out of that. I mean, the finding a common ground, and that the person should identify that, okay, the doctor is somewhat like, he's like me only. We have something similar, and that helps you a lot, at least in treating chronic disease, because you have to have a two-way interaction going on, not one visit, the entire just treatment period, maybe the whole life.
Miss Asha, do you want to come in?
Yeah, why not? Whatever Dr. Baruah was saying, I was in the same page. Like, you should treat the diseased one, not the healthy person. So how to make the difference, make out the difference whether he is healthy or unhealthy or diseased or whatever. When, for example, whenever I would like to start with an example, when I jumped into this counseling field, I never knew where to draw the line, between my patients. I took them as my own extended body, mind, everything. It was like, I am the authority. I need to treat them, or I need to give the solution for everything, whatever they are going through or suffering. Then by practice, initially I went into depression. I was put under medication. And then later on, by experience, I learned how to draw the border, how to draw the line between going beyond and treating the person or the client as my own problems. Whatever they are going through is not my problems. I am one of the ways to give the solutions. So whenever a patient or whoever comes to me seeking help, I would, as Dr. Baruah was putting across, I would like to know their background and then their situation, why they are in that situation and whatever they are going through. Only then, probably around 60% of the times, they will not exactly have any problems. I'm talking about mental health issues, which I deal with. So they would not have any particular reason for their sufferings. It is sort of psychosomatic. So 60% of the problems, there lies in their expressions. They would rather want to tell everything to somebody who will not be judgmental. So that would how I would consider a person who is coming to me seeking help. Then another 40% would be giving some or the other slight solutions and make them find their own solutions. That is how I deal with my clients. Hope I made a point.
Yes.
Thank you. Dr. Tejal, would you want to carry forward that point?
Yeah, I think Asha did the job, because we need to talk about boundaries. And I mean, that's part of the agenda that we were given. And this drawing the line that you're talking about. Sorry, am I audible?
Yes.
Okay, I thought so I recently decided to write a blog, and the first blog I wrote was drawing boundaries. And it's extremely important for us as healthcare professionals, I think, to set boundaries, hold boundaries, and respect boundaries. So this is Dr. Brené Brown. The credit is not to me, the words that I'm using. But she talks about braving the wilderness. And this is a gift from Chitra to me. And wilderness is basically life in general and how we deal with this world. And the first letter B is for boundaries, setting boundaries. Now, if I just very briefly go into setting boundaries, it's a boundary between our personal and professional life, understanding how much we can practice comfortably without stressing ourselves out, without burning out, without ourselves going under depression, anxiety, and without harming our health. It's boundaries between a doctor and another doctor. And sometimes I feel that doctors are the unkindest to each other. And often doctors demand the most time from their fellow healthcare professionals. I'll just illustrate it with an example. I wrote it in the blog, and Dr. Beena and Chitra have read it, about how a doctor contacted me because she had some excess hair on her face and she needed to see me. Now, I was going on a week's leave, and unfortunately, I thought that as a fellow doctor, she would understand that I've just got this one precious week of leave, and I'd probably see her a week later. Now, this doctor sent me a very, very long message telling me that I was a bad doctor. I was arrogant. I was playing hard to get. I couldn't possibly be as busy as I was pretending to be because I needed a week off. She went on to say that she never needed a holiday. She was always available for all her patients all the time. She prided herself on the fact that she doesn't need an off day. So this is the kind of tremendous pressure we place on each other as healthcare professionals. So that's one more boundary. Let me give you one more boundary between a patient and a doctor. Now, there's somebody on Twitter who I will not name, I'm sorry, on LinkedIn, who gives extremely detailed case studies of her patients. She's an MD medicine, and she goes into detail about the mental health problems of all her patients and tries to solve them by counseling them. Now, it's very important to understand that at MD medicine level, internal medicine, we are not trained to counsel people. Because when you go into areas which are painful, you may expose a lot of painful emotions which you're not equipped to handle in the middle of a busy clinic. And we need to understand where to set that boundary. Yes, establishing a sense of connection, establishing a sense of belonging with the patient, which Dr. Baruah and you are doing, Asha, I think is amazing. But we also need to know where to draw the line and understand how much you can probe safely in a busy clinic and how much you delegate to the appropriate trained person, which is a psychologist like you. So that is what I do. One more boundary I would like to talk about is I may be using words which are strictly above 18, but it's called as patient porn. You know, sharing details about your patients in a very crude manner on social media. That's one more boundary that we need to set. Again, I'll illustrate with an example. Recently, a doctor on Twitter who is a forensic medicine specialist wrote about a thief who died because a shutter fell on him. And he said that the thief deserved what he got and karma bit him because he was a thief and he deserved to die that painful death. And this is a doctor making a judgment on a young 20-year-old thief who we have no idea where he comes from, what his life was and what his issues were, right? So we can be extremely judgmental and cruel as doctors to our patients as well. So we really need to be very clear that how much is our brief as a doctor, as a medical doctor, and how much is not. Once we set those boundaries, holding those boundaries in a diplomatic way, in a kind way, but in a firm way is extremely important. And I think above all else, respecting other people's boundaries. And the reason that boundaries is important is because you need to have compassion for yourself. You need to heal yourself, rejuvenate yourself, replenish your energies, and only then you can be of use to somebody else. So we all want to be these helpers and fixers, right? Doctors love getting off on being the person who helps everybody. What happens is we end up measuring our self-worth by the number of problems we fix. But I don't think that it's right to measure our self-worth by the number of people we see, the number of patients we see, or the number of problems we fix. We cannot fix everyone's problems. As a doctor, our brief is to look at the diagnosis, help them with the investigations, explain the treatment plan. Yes, the patient may want to share a few personal details, and you can have a patient empathetic ear and then decide what to do with what they've shared with you. And I think I'll draw the boundary for time and stop here.
Just if
I allows, just jump in now.
Yes, quickly, one comment from Chitra and then Manash, please.
Yeah. So where does this whole thing of boundary tie up to the doctor-patient relationship? So I just want one connecting sentence to join the two. So as we move more and more towards more collaborative approach towards practicing medicine, where we view the person who's seeking help from us as the person and not just a diagnosis, and everybody's spoken about that, Dr. Manash, everybody's spoken about it. As we move towards that, we realize that being that empathetic person itself is a taxing job. If you are going to be having an ideal consultation, I don't think you'll be able to see more than 25 to 30 patients in a day. And so in order to replenish yourself and come back the next day feeling your best self to do your best job, the boundaries and taking breaks for your mind to, deal with it, debrief, and then come back is very, very crucial. And that's exactly why the more we talk about collaborative approaches to practice, where doctors look at human beings, consider all their various personal facets and decide treatment, it's also important that we become that much more protective of our times and draw boundaries and stick to it significantly. That's it. And over.
Yeah. For a long time. Hello, ma'am. How are you? Dr. Usa. Yeah, Dr. Bina. I think Tejal has given us a good perspective of the whole thing, drawing the boundary. And of course, she has mentioned about a doctor blaming her. In fact, I'm not in Twitter, and I'm not having any Facebook account also recently. I deleted. That's my personal choice. But yes, WhatsApp is there, and the worst kind of message or unparliamentary language has come from a doctor, because I couldn't see her daughter. It's exactly the same situation. I was going on a leave, and I had referred him, giving the full address of my colleague Nilakshi. She's a good endocrinologist in Guwahati, you know her. And then I had to bear it for 2 nights. And that doctor used to send me messages during night when he's free after 11. I had to block him. So that is one situation. And I don't think the patients have ever, crossed that line. They are usually quite okay. I mean, I've never had any problem with my patients. And second thing about, I give you a situation like your patient, you are very busy in a busy day. 30, 40 patients are lined up in your clinic. And then you find an old patient. I mean, the patient has been following you for a long time, that lady, and sugars are haywire, and patient is upset and not looking in a good shape, and you're asking, why you are so upset? Why your sugars are bad? And she starts crying. And then you ask why you have cried, then husband says that you have lost our kid recently. So what do you do there? And you have 30, 40 patients waiting. Their time is precious. Actually, it happened to me once, and then I allowed her to cry, and there was silence for almost 4 or 5 minutes in the room. I didn't break the silence. I said, I have a transcriptionist always working with me. I said, just don't do anything. Let her cry. Because let her pour out everything, all emotions. And then she came back to reality and gave her history. And then we gave some anxiolytic. And then drawing the line here, I didn't try to counsel her. I sent her to my counselor. She's there in my hospital. So that's her duty. But that 4 or 5 minutes of empathy is probably very important. Right? That's what is very important.
You're absolutely right. And that's why Dr. Chitra made that point that if you want to practice medicine with an empathetic, compassionate approach, and you will not be able to see more than 20, 25 patients a day. 2022, after that, you don't have anything left to give. So that is again a boundary which a doctor has to decide for themselves what kind of practice they want. And it is possible. I'm doing it. And
I'm doing it now after COVID.
Yeah.
Let me quickly intervene. I'm enjoying this discussion very much. I thought I'd just briefly pitch in to say that number one, I think the physicians who are watching us, physicians who are joining here, we all go through same dilemmas, but specialty-wise, there may be differences. For example, in endocrinology, 2025 may be the right number. So I don't think there is a universal right number there. Number two, there are no strict, stringent boundaries. Boundaries have there are different types of boundaries. There may be boundaries which are porous. There may be boundaries which are very rigid. So we may also want to decide, while we are talking about boundaries, how fluid that boundary has to be. Because in our profession, we cannot be very dogmatic about very strict boundaries as well, because there is a human that side and this side. So coming with that, any more comments from anyone else here?
So Dr. Bina, the boundaries, and I acknowledge what you said. So 2025 is the right number for an endocrinologist, but it may not apply for somebody else. a surgeon can't not afford to pick up a phone call if a patient is serious and has an emergency. But some of my own patients, so it's a rule, I never pick up phone calls, but one of my very old patients, they called me at 6 a.m. and he was vomiting, and yes, I did pick up the call. So thank you for pointing that out, that boundaries are important, but they need to be flexible, and we need to know when to hold them, sometimes when to take a step back, and it's all right. I just wanted to appreciate what Dr. Baruah said, that he just gave 4 to 5 minutes of silence to that patient. I think there can be nothing more beautiful than that, to just give space for a person to vent their emotions without giving, "Arey, koi baat nahi, thode din mein aap theek ho jaoge." You know, the kind of usual language we use in India. And I thought it was so amazing. We think only women are empathetic, but let me acknowledge that men can be equally or maybe more empathetic than women as well.
Yeah, so we have a psychiatrist, Dr. Kavita, also mentioning that for a psychiatrist, that number is even less. So with that, I think this was, these last few sessions have been very, very, I mean, that is what we want. We wanted to discuss various sides. There are no simple answers to many of these complex problems. And if we are looking for simple answers, I think that will be very naive, because it will be simplifying a very, very complicated issue. So the boundaries there, number of patients we want to see, how we refer, do the patients belong to us, what should be the power relationship? It is probably much more complex, like any other relationship. I think relationships are never simple, and so are doctor-patient relationships. Thank you very much. Stay here, because we are having much more interactive discussions.